Welcome to your curriculum on substance use.
Before you begin the module, copy the link on your right and paste it into a new window on your web browser. Do not close your current window, this EDpuzzle website. You will be asked to answer a few brief questions as well as view a patient encounter. After watching the encounter, you will be directed back to this page. This is a curriculum on stigma, language, and substance use. This module will take about 20 minutes total. You'll be prompted at various times to complete multiple choice or free response questions. Patient number 1. You see a 40-year-old man with opioid use disorder. He has been on buprenorphine for the last 6 months and had not used during that time. However, due to recent family stressors, he used heroin multiple times in the last week and has been intermittently taking his buprenorphine. He last used yesterday and is having moderate withdrawal symptoms. What would you recommend to him for his treatment? Patient number 2. You see a 40-year-old man with diabetes. His blood sugars have been well controlled over the last 6 months with insulin therapy. However, over the holidays, he ate many desserts and large meals, and his blood sugars have been running in the 200 to 300 range since. He checks his sugars and gives himself insulin most days, but forgets a few times a week. What would you recommend to him for his treatment? By now, you may recognize the similarities between these two cases. Both have chronic diseases. Both have been on medication for their diseases. Both of their diseases have been managed well over the last 6 months. Both have recently been struggling to follow their treatment plan due to life stressors and are intermittently taking their medications. However, why does the diabetes example, with the possibility of discontinuing insulin, seem ridiculous? Meanwhile, discontinuation of medication treatment for patients with substance use disorders, if they use, is the standard of care in many places. Throughout this curriculum, you will hear from Dr. Jeanette Tétrault, Associate Professor of Medicine at the Yale School of Medicine. Dr. Tétrault's scholarly work focuses on the care of patients with addiction and medical comorbidities associated with substance use. Dr. Tétrault is a physician providing primary care, addiction treatment, and buprenorphine naloxone treatment at a multi-specialty addiction treatment facility in New Haven, Connecticut. Now let's hear from Dr. Tétrault.
Let's start with a quick exercise. Close your eyes. Imagine a hospital room. Fill the room with bouquets of flowers, a get-well-soon balloon, cards, and a patient with a constant stream of visitors. What type of illness do you think the person has? Maybe you're thinking cancer. Perhaps they just underwent major surgery. Chances are you probably didn't think of someone with a substance use disorder. Those living with addictions rarely get that kind of support and concern. Why? Because substance use disorder is one of the most stigmatized conditions, where not only is the patient stigmatized, but also the disease is stigmatized and the treatment is stigmatized.
Let's move on to some questions.
People take drugs either to feel good or to feel better. To feel good is to have new feelings, behaviors, and experiences. And to feel better is to reduce pain, depression, anxiety, fears, and hopelessness. I want you to take a moment and just think about these questions. How do you relax after a stressful day? Do you ever drink a little too much wine or eat too much chocolate? Do you binge watch TV shows? Do you spend more than you want or should on shopping? We all do things that are unhealthy to make ourselves feel good or feel better. Well, it's complicated. According to the American Society of Addiction Medicine, addiction is a primary, chronic, neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestation. Just like other chronic diseases, it can be treated but not cured. The development of a substance use disorder involves multiple factors. There is a large amount of scientific evidence showing that genetics and neurobiology have strong associations with the development of an addiction. Biologic factors, in combination with environmental factors like adverse childhood events and psychosocial factors, predispose a person to develop an addiction when exposed to drugs. The brain's biochemical pathways undergo rewiring after exposure, resulting in dependence and possibly a substance use disorder. We know that addiction has strong genetic factors. This is a table of the genetics of various diseases. It's genetics on the left and the association with heritability on the right. As you can see here, opioid use disorder is actually more heritable than type 2 diabetes. And alcohol use disorder is nearly as heritable as type 1 diabetes. However, we don't know why some people with similar risk factors develop an addiction, while others don't. Substance use disorder is defined in the DSM-5 as recurrent use of alcohol or other drugs causing significant impairment, such as health problems, disability, and failure to meet major responsibilities. It combines the former DSM-4 categories of substance abuse and dependence into a single disorder measured on a continuum from mild, moderate, or severe. Substance abuse is no longer a clinically accurate term. The behaviors that constitute addiction are impaired control over drug use, compulsive use of a drug, continued use despite harm, and cravings. And now, back to Dr. Tetreault.
Stigma is a huge barrier to treatment and also leads to a substantial treatment gap where only about 1 in 10 people with substance use disorder actually access treatment. While there are many potential explanations for this treatment gap, stigma is one thing we all have control over. Everyone from healthcare professionals to families to the press can make a commitment to change the language we use to describe the patient, the disease, and the treatment to destigmatize substance use disorder. A lot of stigmatizing language comes down to labeling. Why do we feel comfortable calling someone with a substance use disorder a substance abuser or addict, or even worse, junkie? We don't refer to patients with diabetes as sugar abusers. People should not be defined by their disease. People are people. Even journalists are being held to higher standards. In 2017, the Associated Press Style Book included updates on how to refer to people with addictions. The new recommendation now advises writers to avoid words like alcoholic, addict, user, and abuser, and instead choose phrasing like he was addicted, or she used drugs, or people with heroin addiction. Healthcare professionals should have the same standard. You might be thinking, but why does this matter? Does language really make a difference? Well, in fact, it does. A 2010 study by researchers at Massachusetts General Hospital compared case vignettes that were identical, but changed whether the patient was referred to as a patient with a substance use disorder versus a substance abuser. Healthcare providers were randomly assigned to a case and then prompted to make treatment recommendations. In the group of providers assigned to the substance abuser group, the healthcare providers were saying things like, "It's a moral issue, and law enforcement should deal with the problem." Compare that to those in the substance use disorder group, where providers recommended that mental health care and other therapeutic services should be offered. The study makes the conclusion, even among highly trained mental health professionals, exposure to these two commonly used terms evokes systematically different judgments. In other words, one little change in language impacted how providers thought about treating patients.
Let's do some practice. You will see some phrases containing stigmatizing language. These phrases are from actual patient charts. Please write down how you would reframe the language using less stigmatizing terminology. I want you to think about the word abuse and when we use it in medicine. The common phrases are child abuse and domestic abuse. These are both examples of a person doing terrible things to another person. So rather than describing a patient as a 25-year-old addict or a 25-year-old man with opioid abuse, you could say 25-year-old man with opioid use disorder. For illicit drugs, you can use use or use disorder. And for prescription medications, non-medical use or use other than prescribed. Non-stigmatizing language does not require extra words or time to use. It just takes practice, and it can be more accurate. Patients are often described as IV drug users, but many patients inject drugs non-intravenously, or they do not inject drugs at all. You could say a person who injects drugs, or PWID for short. A non-stigmatizing way to say this would be, patient has been in recovery for 6 months. But you might be thinking, well, what if a patient tells me that they've been clean for 3 months? Why can't I say that? To answer this, let's hear from Dr. Tetrao again.
I do want to take a moment to acknowledge that parts of the recovery community embrace labeling. Those going to AA or NA are encouraged to identify themselves as an alcoholic or an addict. In these programs, it's accepted and part of the fabric of that approach. However, we feel that patients should have agency to decide how they view themselves. All the time, patients tell me, Dr. Tetrao, being clean is a badge of honor. To which I say, that's great. I'm never going to use those words with you, and will stick to describing what I see rather than labeling. For example, I wouldn't say a patient is clean, but I would say the patient is abstinent or stable.
Remember, patients use many non-medical terms, and it's our job as clinicians to translate them into medical language. Why are terms related to substance use any different? For instance, patients tell you, my chest hurts and I can't breathe. You write in the medical chart they have angina or dyspnea.
There are many compassionate and patient-centered alternatives we can use. I've already mentioned a few in this lesson. To recap, addict can be replaced by person with substance use disorder. Substance abuse can be replaced by substance use or substance use disorder. I hear this one a lot. Not only is abuse stigmatizing, it's actually outdated. The DSM doesn't use this term substance abuse anymore. Additionally, when referring to drug screens, the results are negative or positive, not dirty or clean. Some other examples are replacing problem with disease, or swapping treatment failure with treatment attempt. Lastly, we cannot perpetuate the idea that evidence-based medications used to treat addiction are just substituting one addiction for another, using terms like opioid substitution therapy. Another potentially stigmatizing term is medication-assisted treatment. Medications are not assisting treatment. They are treatment. Rather, we can say opioid agonist treatment or medications for addiction treatment. Again, these might seem like small differences, but they seek to be more neutral and linguistically shift the blame away from the individual.
Substance use disorder should be included in the summary statement only if it is relevant to the chief complaint or presentation. Mentioning it without any clinical relevance can potentially be stigmatizing. If a person meets DSM criteria for a substance use disorder, like we discussed earlier in the curriculum, it should be in the past medical history, just like other mental health disorders. Otherwise, substance use should be in the social history. Let's hear from Dr. Tetrao again.
Don't get me wrong. I slip up. I've said abuse 1,000,000 times. And while we've tried our best to avoid it, you may even come across some stigmatizing language in this course. After all, changing language requires intentional effort, and it's hard. A good place to start practicing is to check your written communication, so being more mindful of how you write patient summaries. For example, your notes should never say, 40-year-old drug user comes in with endocarditis again. Notes are an area where you can begin to edit yourself, and over time, that can translate into your spoken communication. The fact is, there are going to be a lot of people out there who continue to use stigmatizing language. But part of what we hope for those taking this course is to create ambassadors, those that will model non-stigmatizing language. If all you get out of this course is to use compassionate terminology, that would be a win. It may feel like you're on a lonely island using this language, but it can be all the difference to a patient and to the public perception. As providers, our job is not to cast blame or judgment. Our job is to care for people, to keep them engaged in their own health, and to help them achieve their goals with their care. How can we do this if the language we use perpetuates the stigma that patients with substance use disorders face every day? How we conceptualize addiction and talk about addiction impacts how we care for those with addiction. It's the simple difference between saying to a patient, "Ugh, you're using again?" or saying to a patient, "I'm so happy you came in so we can discuss how to best keep you safe and healthy."
We'll finish with a quote from Brian Hampton, a recovery activist who has been in recovery from heroin addiction for more than 3 years.
This is really important to me. I do want to make it clear, I actually identify as a person in sustained recovery, especially when I'm talking to folks on the radio and outside of my own personal recovery community. And that's an important distinction for me because I believe that for a very long time, the media and the culture has called us addicts, and it has stigmatized us. It has put us into this box. I am so much more than an addict today.
For the last part of your curriculum, please return to the Red Cap page to review what you wrote for your patient encounter at the beginning of the curriculum. While you're reading, please think about the following questions. Would you change any of your language? And if so, what language would you change?